as we can and get them into clients' homes safely. If we can help you, let us know. And of course, we have the wonderful Stephanie Altman doing our placement services valley-wide if you need any help with that. She's kind of been keeping up on top of who has and who doesn't have COVID and what's going on. So that's been really useful information if you have somebody looking for someplace to go. And we also have our nurse care manager for care management services valley-wide. So anything we can help with, let us know. And thanks for joining us today. With that, I'm going to introduce a friend, associate, guy I've known for a long time, Dr. Paul Lynch. He is a double board certified and fellowship trained. Pardon me, I'm trying to read while wrong glasses on. Physician who's dedicated his life to the eradication of pain for his patients. Dr. Lynch is passionate about diagnosing the most complex pain conditions and treating those patients with cutting-edge and innovative therapies, excuse me, like stem cell injections and spinal cord stimulation. Dr. Lynch is also the co-founder and sits on the board of directors for Pain Doctor Inc., leading pain management company committed to delivering the highest quality, evidence-based, and affordable pain care to patients through the United States. He currently practices in Scottsdale, Arizona, and there's a lot more on his background that I'll pass as long as Paul doesn't mind, but Dr. Lynch is passionate about educating the public about responsible opioid management and reduction. Throughout his career, he's focused on helping patients stop or reduce their opioid use due to the harmful side effects and risks. He's been, just from my own knowledge, he's been a very prominent person in the pain management field, and through this COVID episode, pandemic, whatever words we want to use for it, he's become very, very, very knowledgeable, did some very interesting stuff. And with that, I'm going to let Dr. Lynch tell you his story.
Thank you, Scott. I appreciate the kind introduction. I'm really impressed with this organization as I listen to all of you guys introduce yourself. I mean, what an incredible organization to support each other and have resources for the elderly. I'm glad I met you guys, and hopefully I can be a resource for you in the future as well if I can help with any of your clients. So I'm an anesthesiologist, as you said. Whenever I speak, depending on how much time I have, I like people just to kind of understand a little bit who I am and what is an anesthesiologist and a pain management doctor. What does that really mean? My whole life, I actually wanted to be a psychiatrist. I grew up in my parents' house. My mom's a nurse and my dad's a licensed clinical social worker. And he worked as a therapist. And so as a kid, I would read all the books on the shelf. And as a 12-year-old, I had strong opinions about how to have a strong, healthy marriage and how to raise your children. And so I really liked psych and wanted to be a psychiatrist. So I went to medical school with the intention of being a psychiatrist. Actually made it all the way through medical school with about 3 weeks left before I graduated. My mother-in-law was diagnosed with pancreatic cancer, and it was rapidly progressive, and she was hospitalized, and the family started reaching out to me to ask my opinion on how to help specifically with her pain control. And I didn't know the first thing about pain management, which I've come to find is really common in the medical community, is if you're not a pain doc, your training on how to treat pain is pretty minimal. I honestly didn't know that pain management was a specialty. This was 2002. And so I started researching options to treat her pain. She had lots of tumor in her belly, and she had 7 fractures in her spine. And so I found these procedures that we could do to help with her pain. And in the process, decided that I wanted to change careers, which was really disruptive. And it's another story for another day. But with about 3 weeks left before medical school, I decided, no, I'm not going to be a psychiatrist. I want to be an anesthesiologist. And it's not quite that easy just to make that decision. And so I did that. And the other part of the story that's interesting is my best friend, his name's Torrey McJunkin. He did the same thing. So I went over to his house about midnight because, this was 20 years ago. We stayed up super late. Now I've got 5 kids. I'm in bed by 8, but I went over to his house at midnight, and I printed out all these things that I could do as a pain doctor and the procedures. And one particular really stood out to me. It's called a vertebroplasty, where we could fix fractures in the spine in a minimally invasive way. And I showed it to him and said, this is what I'm supposed to do in my life. And he looked through it and basically said, me too. And so we, at the same time, 3 weeks before we graduated medical school, dropped out of our respective careers and decided to become pain docs. I tell you the part about him because he's from Arizona. His dad is a chiropractor here in town that started practice in, I think, 1967. And we decided to come back to Arizona to start our first clinic. And so we came here about 2007. We started what's called Arizona Pain Specialist. And we've got clinics throughout the valley. I will just say, such amazing resources on this call today. If you guys ever need help with your elderly patients, let us know, because I take a lot of pleasure out of helping the elderly. We do take Medicare and all the Medicare replacement plans and all that. And I get a lot of joy out of helping someone who's suffering. So I've practiced here for the last 13 years. My first job was over at Mayo Clinic, and Mayo Clinic was such an incredible place to work. I worked in the OR doing anesthesia, but I also worked in the pain clinic. And I was inspired by the way they practiced medicine. They were very organized. They had a comprehensive integrated approach. And when I started my own pain clinic, I tried to kind of set it up, honestly, a lot like Mayo with their approach. When I worked in the pain clinic at Mayo, the patient would often come in at like 8 a.m. for an MRI, 9 a.m. for physical therapy, 10 a.m. to see me. And by the time I saw them at 10:15 or so, by the time they got checked in, I would usually have an MRI report from the 8 a.m. MRI. Half the time I would have a report already from the physical therapist. I was very inspired by it. And so I tried to kind of set up our approach to be similar with like a comprehensive approach. We grew pretty fast here in town. And then I started doing management around the country. And I spent the last 12 or 13 years running my practice. I'm the CEO, but also running clinics throughout the country. I've worked with the White House on developing protocols for pain management, because the thing that really gets me passionate is getting patients off of pain pills. And once again, that's a longer story too that I won't get into, but through personal family members' struggles with addiction, I've really become passionate about getting people out of pain, but not necessarily using opioids. Now, some people definitely need to be on opioids, but whenever we can get them off, then that's what I try to do. And so if you fast forward to COVID, the first question that I've got a lot is, why did I go to New York City in the middle of this crisis? And I just want to tell you guys that story a little bit. So I trained in New York after deciding that I wanted to be a pain management doc. My wife was at NYU Dental School, and through just probably a miracle, I was able to get accepted into NYU for anesthesia. So it was one of the best programs in the country, and I was able to get in. And my wife and I were there at the same time in the early 2000s. Matter of fact, we were there during 9/11, and 9/11 was actually 9 months before the story of my mother-in-law. We were there in the fall. My wife was starting her first year of dental school, and I was finishing up medical school. And I can remember I was in Queens the morning that the towers went down. And I saw it on the TV, and I looked out my window and I saw the smoke, and I just got on a subway and I went into the city, and I went as close as I could. I put my white coat on, I think, so people would think I was legitimate, would let me through. And I went straight to the hospital that was near Ground Zero. It's called St. Vincent's. And I just showed up and said, what can I do to help? And they basically sent me home and said, there's really no survivors. Everyone is dead. And I found out later there were some survivors, but mostly everyone, that was involved died. And so I can still remember to this day, just the helplessness I felt wanting to help, seeing the tragedy in my city and not being able to do anything. And so when COVID hit, I think we all have our own experiences, but in early March, mid-March, late March, it became clear that this is a real emergency, a pandemic. And I started getting messages from my old training hospital. I trained at NYU. One of our hospitals was Bellevue Hospital, which is the oldest hospital in the United States. And it's a level 1 trauma center in Manhattan. We take the poorest of the poor and the sickest of the sick, and just an incredible place to train. And so I started getting messages that the anesthesiologists were getting sick. And so at that time, about 1 in 3 of our attending our faculty contracted COVID. By the time it was all over, it was about 50% of our department got COVID. And so they started sending out kind of distress alerts to people who had trained there. We need help, if anyone can come back to help. And I think the feeling that I remember having at 9/11, where I felt helpless, this was like the opposite. I knew that I had a skill set that could make a difference in the middle of a crisis. And, I had to go. So I made the decision to leave my practice here where I, in the big picture is pretty comfortable seeing patients and air conditioned room in Scottsdale and talking to them. And I'm the CEO, so I get to make decisions and make the schedules, and everything's nice and easy. And I see my kids and my wife at night. I flew to New York. I stayed in a hotel in Times Square. I had to walk about 2.5 miles every day to Bellevue Hospital. There weren't really taxis running or anything like that. And went for about 3 weeks. And the experience that I had is something that, I'll remember for the rest of my life. And I want to tell you guys a little bit about the experience that I had, a little bit about how I got sick and how that affected me, and then leave you guys with a couple of take-home points on what you can personally do to stay safe and protect yourself and others. So I've told this story several times, and what I've actually found is the best way to tell a story is just to tell you like a day in the life, like what it was like one day. And then there's certain things that would happen that I can tell you along the way. But so I would get up in the morning and I would leave my hotel in Times Square, because the hotel put me up for free. I wasn't being paid when I was there. I was volunteering, but there was multiple hotels in the city that put up doctors and nurses from around the country that went to work. And so the hotel that I was selected for was about 2.5 miles away. So I would walk downstairs, and the first thing you would notice if anyone's been to New York is the streets were quiet. They were empty. There was no sounds or smells or all the typical things, of New York that you associate. It was just quiet. It felt like, a scene from like an apocalyptic movie. The city was on total shutdown. As you look back on this time, I got there in early April. By the time all my paperwork was finished and I was approved, I showed up on literally the worst day of the worst that it's ever hit us. Just for reference, I think Arizona had 27 deaths today that were logged, and that's a lot of deaths. That's a lot of people, and it's incredibly tragic. The first day I showed up in New York, we had 1,000 deaths in the city. And we had, the first 3 days I was there, we hovered around 1,000 deaths each day. And so as I walked down the streets, it was literally quiet. There was no one on the streets. I saw police officers, and then I saw the military. It felt a lot like a military state. As the military, they weren't there to enforce martial law or anything. They were actually there to help. They were there to help with the hospitals. We were building hospitals in Central Park, and we had a hospital off the coast in the East River. When I got to Bellevue Hospital, one of the first things I noticed was refrigerated trucks out front. And I immediately knew, what it was. But as I learned more later, there were so many deaths occurring in the hospital. There was no place to put all the bodies. There was no, everything in the city as far as healthcare was at capacity. But one was just the deaths. There weren't enough people to have funerals or to bury the bodies. And so they just started stacking up in trucks in front of the hospital. And so I've got photos of some of that, of 20 trucks in front of the hospital with just filled up with bodies. When I went in, one of the most incredible things, Bellevue is a massive structure. It's about 300 feet high. It's like 25 floors, but the floors are like all double floors, so it's really tall. Maybe it's tall, maybe it's 500 feet high, but it's this massive kind of building, and they have a pretty intricate elevator system. And when I walked in on the first day, there was about a 1/4 mile line to get on the elevator. Which I've never seen anything like that in my life. And what I would come to realize is the entire hospital was at double capacity. Like when I got to the ICU, we had 2 patients in every room. That's the way we kind of, doubled our capacity overnight, is we just put 2 patients in every room. And so when you have 2 patients in every room, you need 2 nurses for every room, and you need, 2 janitors, and you need 2. So everything was kind of at capacity. And so we couldn't just double the elevators. And so we started walking the stairs. And so we would walk 300 or 400 feet up to the floor in the morning, which would take 15 minutes. And we would arrive on the floor, exhausted. The first day I worked there, I worked on a airway team. And so as an anesthesiologist, and I just want to make sure you guys understand, I've not practiced anesthesiology in 12 years. And so as a pain management doc, my full-time job is seeing patients in clinic and doing procedures and helping them with their pain and managing physical therapy. And, I'm very into comprehensive integrated care, and I'm the CEO, and half my day is running the business and half my day is seeing patients, but I don't do any anesthesia. So for me to go back and work in an ICU and intubate patients was scary. It was scary because I hadn't done it in a while, but I felt like it was the right thing to do, and they really needed help. So my first day, they put me on an airway team, and the very first day we intubated 10 patients. And I'll just say right now, depending on what news you watch and what your circles are, there's some controversy where you hear some people talking about, oh, we're intubating 2 people too early and ventilators are the wrong treatment. And I've heard these types of things. And I would just say, it's just not true. There were patients that were actively dying in front of us and couldn't get oxygen. There really is no other treatment. We were doing is the very best we could to let them breathe on their own as long as they could. And then at a certain point, we would have to put tubes in to help them, breathe. And the very first day, I was called to intubate 10 patients, and I was just one team. There was probably 3 teams like mine in the hospital. And I was reading lots of stuff, preparing. What I realized going in was the data right then was showing about 70% of patients who got intubated would never wake up. And as we look back on it, there was a new study in JAMA, the Journal of the American Medical Association, that shows that it's more like 88% of the people that got intubated, they would never wake up. They wouldn't survive. It's just how crazy terrible this disease is. So when I got there, I was very acutely aware that I might be the last person that they ever talked to. And I'm just going to pause the story for a second to say, when I started our pain clinic here in town, my mother-in-law was a very strong figure in my mind on why I went into pain. I saw her suffering at the end of life, and how much pain she was in. And so when my best friend and I started our practice, we made our mission statement that we would provide the kind of care that you would want for your own mom or dad. And that might seem cliched, but the reality is I've seen thousands and thousands of patients over the years, and some are really easy. It's a 40-year-old male who has low back pain that goes down to his foot, and he hurt himself on the job, and we do an epidural injection, they get better. That's easy. But sometimes it's really complicated and it's difficult. We don't know quite what to do. The person's had 5 or 6 spine surgeries, and they're on really high doses of medication, and they have history of addiction, and they also maybe have a new diagnosis. And so sometimes we don't know quite what to do. And in those situations, what I teach is that I always pause before I go in the room. And I think, what would I want if this was my own mom or dad, if this was my own family member? As I get older, I think a lot about my own brother or sister. And I want that to be my guiding light, that if I don't know quite what to do, what would I want for my own family member? And I think it's never really let me down. But what's interesting is when I trained in New York the first time, I certainly did not practice medicine that way. I don't think I was a bad doctor, but I worked in ICUs for months at a time and saw the sickest of the sick, and patients who were dying and patients who would live. And I think I put like a cocoon around myself to protect me from the pain of it. The roller coaster rides of, saving people and some dying are very difficult. And over a 4-year period, I think I just learned to really wall myself off from it. So back to my story, if 20 years ago, if I got called to a floor to intubate someone, I don't think I would know their name except to maybe write a note afterwards. I wouldn't know their age. I wouldn't know anything about their family. I would go in, intubate the patient, and get out, do my job. But this time it was different. After years and years of practicing a certain way and trying to treat every patient like my own family member, and being acutely aware that I might be the last person they ever talk to. And additionally, and this is where it gets really, emotional and difficult, the patients didn't have their loved ones with them. Because COVID was raging through the city, it just wouldn't make sense to have the family members in the hospital with their patients or with their family members, because then they would get it. And so this patient, whether he was 40, 50, 60, or 80, was dying alone. And I was the last person there to talk to him. And so with that as a background, I would go into the room, and we usually have about 5 minutes to get everything set up. You don't just run in. I mean, if someone just stops breathing, like having a cardiac arrest, then you run as fast as you can and intubate. But in these situations, it's someone that you've been managing on the floors for days, and it's really clear that they're not going to survive. And so you have time. And so when I say they're not going to survive, they're not going to be able to breathe on their own much longer. We would go in, we would set up the ventilators, we would prep the medications, we would connect the oxygen to the wall, we would do all the things. And we usually were working in teams. And I started taking the role of holding the patient's hand and asking them questions. Where are you from? Tell me about your family. I thought about if I was in this situation and this was the last conversation I was going to have, what would I want to talk about? Sorry, whenever I talk about it, it's hard. I think if I was dying alone in a hospital, I'd want someone to ask me about my children and the life I lived. And I'd want to talk about things that made me happy. And so that's what I did. And I did it over and over and over and over for 3 or 4 days straight, just going floor to floor and meeting people and asking them their stories. I can remember one gentleman, he told me that he was an immigrant from another country, and he was so proud of himself and the work he had done. He'd become a citizen. He lived in Queens, and he got a job at a university, and he worked in the surgical department at a large teaching hospital. And he could just tell he was very proud of the work he had done. I think looking back on it, I don't think he had any idea he was dying. I don't think he knew that this would be his last conversation. But I asked him about his family. I asked him about his kids, his job. And then we found common ground. We talked about the Yankees. And I was in New York in 2001 when the Yankees went to the World Series, and Jeter had his famous moment after 9/11. They called him Mr. November. And so we started talking about Jeter. And this gentleman just lit up. He was so happy. And that was the last conversation he ever had. He died about 3 or 4 days later. And I struggle for this part of the story. I'm sorry, but I feel like if nothing else, I went to New York to help several people die with dignity, not alone, but someone holding their hand and asking them questions and helping them smile. So I'm going to try to move on to other things because it's difficult, but in the first couple of days, that's pretty much what I did. Is I just went floor to floor and we intubated and we had conversations. After about 3 days, I got settled into the ICU, and I worked on a team. As I said earlier, we had 2 patients in every room. So my ICU had 12 beds, but we had 24 patients. And so I would take generally care of about 6 patients a day. We'd work 12-hour shifts. We'd round in the morning, we'd make plans, and then all day long we would manage to the plans. And this is where things were very different than what I did in the past as well. In the past, we would get our work done as fast as we possibly could, and then try to move on to other things or sit for a while waiting for the next admission. What happened in New York is we would do the work, and then I would spend a large portion of my day, I would say 25 or 30% of my day, calling family members because there was no family members allowed on the unit. And technology is so much better than 20 years ago. And so, that was part of it, and COVID was part of it. But we started FaceTiming, and I would spend 2, 3, or 4 hours a day FaceTiming with family members where we would just basically hold up our phone and we would show the family member their loved one, and just seeing them was enough sometimes to give comfort to the family members. And so we would take care of the patients. We would FaceTime. Social work started doing it first, but they got overwhelmed. There weren't enough social workers in the hospital. And so all the doctors, we started doing it. And so we would spend, time talking with family members. And the thing that I would tell you guys, as we see this starting to hit Arizona, when I went to New York, I thought it was a disease of the lung, and it is. But it's so much more than a disease of the lung. And this is what people, don't realize. The people that were dying in our ICU, all of them across the board, it had moved beyond their lungs to a disease of the body. And so it affects the blood. The blood started clotting. And as the blood started clotting, you would have kidney failure and heart failure and strokes. It was affecting the blood vessels where they would get inflamed, and it would affect inflammatory markers. We would have, for those of you in healthcare, we would have SED rates and CRPs and D-dimers that were off the charts. All these inflammatory pathways were off the charts, and it affected the immune system. So monocytes would be almost undetectable, almost like HIV or something, where you wouldn't be able to fight infection. Invariably, across the board, they had kidney failure. Early on, and even now, you hear a lot about ventilators, but ventilators weren't our limiting factor. Dialysis machines were the limiting factor. We didn't have enough dialysis machines. So in New York, they sent what they called FEMA ventilators, and they were like small little compact ventilators where we could ventilate a patient, but we had enough ventilators. We didn't have enough dialysis. And so there's an old school way you can do dialysis called peritoneal dialysis, or PD. And we started doing peritoneal dialysis on every patient. That's not the standard of care. We did it because we didn't have any other way to clear their, basically their kidneys. And so we ran out. We probably only had 50% as many dialysis machines as we needed. And for those that don't know, peritoneal dialysis, we just basically put what's called the dialysate directly into the abdomen and let it sit there for a while and then drain it off. And it's a really old school way to do it, but that's what we had to do to keep them alive. Their blood was clotting. They were having strokes. Their kidneys were failing. It's just, I did not prepare for that. When I went to New York, I thought it was going to be a lot of managing their lungs on ventilators, which it was, but the lungs were just one kind of part of it. And so I think that's super important to realize here in Arizona as we're going through this. I will say that while I was on the ground, I'm kind of a teacher, and I like to write, and I've published. I decided to kind of document a lot of my findings. And so my mentor, one of my best friends, is the director of perioperative care at Bellevue. And we started writing a document on what we did in the midst of this crisis. And so if anyone is working with hospitals, or if you're dealing with this and you need help, you can reach out. I'll send you that document. It's about a 15-page document, but it's basically just how we set up the hospital, how we screen patients, how we kept the COVID positives separate from COVID negatives, how we dealt with dialysis, for example. So we wrote all this. So if there's anything, if any of you guys are dealing with this on the front lines and need help, just reach out to me. So I had 4 things I wanted to talk about today. First was just my intro, why I went to New York, what I saw on the ground, and then I wanted to leave you guys with some teaching points, like what you can do. Before, I will just say I got sick. I don't want to belabor that too much, but I got sick about 2 weeks in myself. I started just getting really, really tired, where we'd be on rounds, and I've been a doctor for a long time, and I work long hours. That's not unusual. But I would, be walking, and after I would present my patient or whatever, I would just sit down until it was kind of my turn again. I was just having a hard time standing. And that lasted for 3 or 4 days, and I didn't realize it was COVID. I think I just thought I was tired from all the work. And then I told the doctor that recruited me to come help how tired I was and how I could barely stand. And she just sent me home, basically said, "You're sick, something's wrong, this doesn't make any sense." And so they sent me home and they tested me, and I ended up coming back positive. And I won't bore you with all the details, but I got very sick. My oxygen fell into the 80s. I'm fairly young and healthy. And, but my oxygen was very, very low. My breathing was difficult. I had a fever. I was just profoundly weak. I was really sick for 3 or 4 days, but I didn't go to the hospital. I kind of managed myself in the hotel room, which maybe is not a great idea, but I had a pulse ox, and I would put alarms on. So if I fell asleep and it went too low, I'd wake up and take, deep breaths. And I kind of got through the worst of it, which took about 3 days. And then I ended up quarantining for about 2 weeks. And now it's been about maybe 2 months since I got sick, and I'm still not completely better. For the first 6 weeks or so, I took a nap every single day. Every day I would feel tired. And, luckily in my business, I make the schedule. And so I would just schedule myself nap time. But it's kind of weird. My entire career, I've never taken naps, during a business day. But I literally would see patients in the morning, and I wouldn't be able to work in the afternoon unless I lay down for an hour and a half. So we were talking about before the call started, we just don't know about COVID, what's the long-term effects going to be. But it was pretty difficult on me getting through it. We don't really know long-term what the effects are going to be on the lungs. I still will check my pulse ox, and it's still low sometimes, like really low, like 90%, which if you work in, healthcare, 90% doesn't sound like it's not as good as it sounds. Like we think 90% is like an A, like, oh yeah, you have 90% of the oxygen. But if your pulse ox is 90%, it actually means you have about 60% as much oxygen in your blood as you're supposed to, because it's a logarithmic curve. So for me as a young 44-year-old, fairly healthy person, to have oxygen saturation of 90%, it's a little bit scary. And I tell you that once again, because you guys are in direct positions to influence people and to make sure we can protect as many people as possible. Not so you feel sorry for me, but just that we all, take this seriously together. I want to teach 2 things, and they're both numbers. So, because I like numbers. So one is 4 things you guys can do to stay safe and to protect those that you're working with, particularly elderly. I'm really happy to talk to this group because the people that need to hear it are people over 65. And so we all need to hear it, because we all spread it, but those over 65 are most at risk. So the first thing I want to do, actually, I'm going to do it in different order. So the first thing I want to do is I want to teach 3 groups and how we should be dealing with this. So 3 groups. And then the second thing I'm going to teach is 4 things that we can do today. So the 3 groups, and this is, for a long time, I tried to stay out of teaching what we should and shouldn't do, because I would say, I'm an anesthesiologist, not an epidemiologist. You can make a rap about that if you want. Anesthesiologist, not an epidemiologist. So I'm an anesthesiologist, not an epidemiologist. So I don't know that I should be teaching everyone how to deal with this public crisis. But the more it goes on, I realize people just need voices. And so I'm going to give my opinions and give my voice. So, and this is pretty much the way I've been managing my clinics, my business, my own parents. There's 3 groups. So group number 1, and this is the group you guys work with. Group 1 is really, really high risk. And when I say high risk, like maybe as high as 10% death rate if you get COVID. So group 1 is over 65 or significant comorbidities. Comorbidities, we found, there's a lot of things on the list, but the ones that are most associated with death is diabetes, heart disease, lung disease, and obesity. So diabetes, heart disease, lung disease, and obesity over 65, there is a really high death rate. And I don't care what you see in the media or what you're seeing on social media. If you're over 65 and you get this, you are at risk. I would just call it a 10% death rate for this discussion. Group 3 is me, just barely. Less than 45, no comorbidities. And the death rate in this group is really, really low. I have asthma, so I have a little bit of comorbidity, so I'm probably not in group 3, but a classic group 3 called a 25-year-old male or female who doesn't have any background. If they get the disease, they're probably going to be fine. Mathematically and statistically, they're going to be okay. And so, and I'll come back to recommendations on this. Group 2 is kind of in the middle. And I actually say in my teaching, it's easier to focus on group 1 and group 3 than group 2, because group 2 is a little bit questionable. If you get it in group 2, which is 45 to 64, maybe minor comorbidities like hypertension or a little bit overweight, the death rate overall is probably close to 1%. And so you're probably talking a death rate in group 3, less than 45, of 1 in 10,000. The death rate greater than 65 with comorbidities, like 1 in 10, such a huge difference, right? And then the middle, it's maybe 0.5% or 1%. So as we start to think about public policy, what I would say is, I don't know that the government's going to have the stomach to shut down again. I don't know that the American people or Arizonans are going to accept another shutdown. But, and I would love it if we would, because I think as a doctor, I think we just need to put a lid on this. But if we can't, if we don't have the stomach to politically do the things that we need to do, then I think we need to start at least thinking about the vulnerable in our community, and you guys work with them, greater than 65 or comorbidities. They should be completely locked down. Like my mom and dad, when this hit in mid-March, it was clear that it was a big deal. And I told them, go to your house and don't leave your house until this passes. And whether that's 3 months or 4 months or 6 months, you need to be ordering on Amazon. So my mom and dad have not been to my house in 3 months. My kids haven't seen their grandparents. But that's because I know that there's a 10% chance that they will die. My mom and dad are both 70. And I don't, time's going to pass. This isn't going to last forever and ever. And I think my mom and dad can go hole up in their house for a year. And a year sounds like a long, long time, but that's how long this could be. And so that over 65 group, we all need to manage it like it is a emergency. Now, the group 3, less than 45, if you want to go back to your job, if you want to go to Costco, if you want to go back to church, if you want to do all these things, I think you can. But I think the teaching here is, do not interact with people in group 1 if you're going to go live your life. If you're going to say, well, I want to go back to, I use church as an example because there's a lot of people that have been like, really want to go back to church. Okay, fine. If you're going to go back to church, but do not go to church and then go hang out with your grandma who's 75 years of age. I think that's a very unchristian, like dumb thing to do if you understand the science. Now, if you don't understand the science, then maybe I give you a bit of a pass, but I've tried to spend a lot of my time explaining the science to people that this disease is about 2.5 times more virulent, not virulent, but whatever the word is for catching it. They talk about like attack rates. You're about 2.5 times more likely to catch this than if someone around you had the flu. And then once you have it, it's probably 10 to 20 times more likely to kill you. And so if you want to go to the bars in downtown Scottsdale, maybe that's less controversial than church, that's fine. But then don't go interact with someone who's over the age of 65 or who has comorbidities. So the first thing I wanted to teach is 3 groups. So group 1, greater than 65, comorbidities, we all need to be working together to keep them sequestered, quarantined. If we need to bring them food, buy them food, whatever we need to do. The group 3s in society, like myself, we need to be doing everything we can to keep the group 1 at home. So for example, for my clinic, we just don't bring them into the clinic. We tell them, we want to see you over telemedicine. And so we shut down 3 months ago. And while a lot of other medical clinics are opening up, we're still 80 or 90% of all of our visits are telemedicine. If someone is 42 years old and wants to come to the clinic, then we'll see them. But we also ask the question, hey, if you come into the clinic, are you going to go back and interact with someone who's over 65? Because it's the same effect if they come into our clinic and get whatever germs are in our clinic and then take it back. So that's the first thing, is the 3 groups. And I think it's a smart way that we should start talking about it. The second thing I'm going to teach, and then I'll be done, is what are the 4 things that we can do today. And you guys have probably heard these, but I want to teach it in a spot that you can remember it. So number 1, you guys will probably guess this one: wear a mask, right? And so wear a mask. And I like to teach it a little deeper than just wear a mask. Wear a mask commensurate with your risk level. Cloth coverings that the CDC has recommended, that's great, but it's really not going to help you keep from getting it. So if you're a healthcare provider, you should be wearing an N95. You can even get better than an N95. You look on the internet, look around. When I first got to New York, I had docs walking around with 2 filters on either side of their face and N100 masks. And there's all sorts of ways you can filter out even more than an N95. So if you're a healthcare worker and you're at risk all day, then you should wear N95s or better. If you are 65 or older, you should probably get a hold of the N95, but wear a mask commensurate with your risk level. Number 2 is wash your hands. But I'll go a little bit deeper than just wash your hands. I think you should wash your hands 10 to 20 times a day. Okay. No one does that, but that's what you should do. When this first hit, I bought 5 gallons of alcohol to drink. And I also, no, I'm just kidding. I bought 5 gallons of rubbing alcohol, and I also bought aloe vera, and we made our own Purell at home, and we made little bottles, and we would carry them around, my wife and I. So I'd have it in my pocket. And if I would go out and touch stuff, I would just wash my hands constantly. And anytime you touch something not in your own home, you should wash your hands, because we are finding more and more that it's not living on surfaces as long as we think, that it's probably not the primary way that it's being transmitted. But I would still say we don't know what we don't know. And so continue to wash your hands constantly. So number 1, wear a mask. Number 2, wash your hands 10 to 20 times a day. Number 3, socially distance. And I'll say this again, socially distance commensurate with your risk level. So if you're in group 1, greater than 65 or comorbidities, you should do what I call extreme social distancing. You should quarantine at your house and not leave. That's what my mom and dad have done for 3 months now. And I know it sucks and they don't like it, but they're still alive. And this time's going to pass eventually. They can catch up on watching shows and Netflix and read books. And eventually we're going to come out the other side. So if you're in group 1, I would say extreme social distancing, complete shutdown, lockdown, don't leave your house. If you're in group 3, you should still socially distance. You should try to stay 6 feet away from people. If you're going to go to an event, do outdoor events. The data is pretty clear that indoors is worse than outdoors. Indoors, it circulates in the air, and, there's all sorts of case reports of people in restaurants getting it, on airplanes getting it. And when I say getting it, we're like, everyone gets it in an area. But outdoors, if you have to go to an event, go to an outdoor event and stay 6 feet away from people. So socially distance is number 3. And number 4 is screening. And I actually grouped 3 things together on number 4. So it's screening, it's testing, and it's tracking. And this is more for the government, but for a lot of you that run businesses, anyone who comes into your business, you should screen them. The easiest way to screen is for temperature, but you can also screen with questions. You can ask them, have you had these symptoms? And then if someone screens positive, then you test them. And we're getting to the point now where it's easier to get access to testing. So you screen. If you find someone that has suspicion of the disease, you test. And if you find the disease, then you track. So tracking is a whole other conversation, which I won't get into. But my 4th point is screening, testing, and tracking. I'm going to repeat those again because the teacher in me, you got to tell someone what you're going to tell them, and then tell them what you told them. So I'm going to tell you again. Number 1 is wear masks commensurate with your level of risk. Number 2 is wash your hands 10 to 20 times a day. 3 is socially distance commensurate with your level of risk. And number 1 is we'll screen, test, and track. So, and I would just say a number 5 is pray. If you are the praying type or religious, I would just recommend that you all be praying during this time. I do think that we need God's favor and a miracle to get through this. Arizona has been number 1 in the United States 7 days in a row per capita. So on a per capita basis, we're number 1. And being number 1 with the elderly community that we have is kind of a recipe for a lot of death and dying over the next month. And I think we kind of need God's favor. When I was in New York, I would call the patients every day. And at the end, I would ask them, is there anything else I can do for you? And I remember one gentleman, his loved one I was taking care of. And he said, will you pray for me? And I said, I'd be glad to pray for you. What religion are you? And he said, well, I just recently converted to Islam, but I don't care what religion you are. Let's just pray together, for my family member. And so we prayed together. I, as a Christian, him as a Muslim, and we prayed for his brother-in-law. And I would just say that that's going to be an important part of this. I think we got to trust God, and we got to ask God to help us through this time. So with that, I think I am finished, and I think I went a little longer than I was supposed to, but I can take questions for the next I don't know, 10 minutes or
Yeah,
so.
yeah, we really amazing presentation, Dr. Lynch. We've seen just tons of comments coming across the board. I don't know if you were able to see them.
I
Just
did
talking
not. I've
about
seen it.
how the people were crying, including my wife sitting here was crying, and it's I really appreciate you speaking today, because I think that there's too much of a tendency to view this in a black and a white, meaning that oh, only this small percent die, everybody else okay, and there's so much gray area in between that dying and being fine that people don't pay enough attention to. And there's so many people that get very sick, and there's so many people that end up with lung damage and things we still don't know. And
Right.
so somebody who's been right on the front line like you were, it was amazing to hear what was going on in New York at the height of this. And again, I told you earlier while we were private that you're both brave, heroic, and crazy for going. And with that, I'd like to open up. Who has questions? I'm sure a lot of you do. If you want to unmute and try and jump in, if we have to, we'll try and get more organized than that. But let's just try that for now.
I have a question. It's Mike Rasmussen.
Go
I
ahead,
don't
Mike.
know how to raise my hand.
Go ahead. Just talk.
I was just wondering about the whole thing. If you had it, this is ridiculous, but I had a friend say, yeah, I just want to get it and sequester myself for 2 weeks and get over it, and then I can't get it anymore. There's so much information about that. You touched on that. What is the deal with that? If you have the antibodies, can you get it again? Can you still pass the virus?
It's nice to meet you. Thank you for your question.
And I don't know the answer to that. That's why I'm asking.
Yeah. So I will say, first of all, as a disclaimer, I'm an anesthesiologist. I'm not a virologist or epidemiologist or any of these people. I've probably researched this and read about it more than 99% of people, though. And so I'm constantly trying to educate myself about it. And with that as a background, I would say we don't know. We just don't know, because they call it the novel coronavirus for a reason. It's new. We've never seen it in the history of the world, and we're rapidly studying it. There's been like 50,000 papers published on it. And one paper will say one thing and another will say another. I think our knowledge of immunology tells us that if you get a certain virus, your body will create antibodies, and then you'll get a certain period of time where you're immune. But the question is how long? It could be as little as 3 months. With like the common cold, you guys are aware, we get that every year, right? It's the same coronavirus every year, and we get it over and over and over. And so most people, their best guess is if we get it, you're going to have immunity for at least a year. Could be as much as 3 years. It could be as little as 3 months, but we don't know. And so that's why I think it's a terrible strategy to go get it on purpose. Even me, I got it. I have antibodies now, but I still wear a mask when I'm in public, and I still try not to get it again. And so we'll know more probably in the next 6 to 12 months, but then it'll be too late. So in the meantime, stay safe.
That's the most honest answer I've had is we don't know. So thank you.
You're welcome.
I saw Melinda McMillan raised your hand. Go ahead if you can unmute.
Thank you, Dr. Lynch. That was an incredible presentation. I know this is going to be like a big question, and if you could just streamline just a few tips for home care for us. Do you have any things that you can add to your 4 points about us in home care, specifics that we can do? We all have our protocols that our companies and our franchises are giving us and what we're doing with our caregivers and our patients. But as we go in hospice cases and home care cases, do you have anything specific for us that we can implement?
Yeah, thank you for your question. It's nice to meet you. So the most important thing is you should think about protecting the patient from you, not you from the patient. And so you're going around to different businesses and you're out and about, and I would think of yourself as like a vector, and you need to be there to take care of the patient, so you can't stop it. But I would say, number one, if you can do telehealth, I know it's a long conversation, but if there's times where you don't have to go and you can do it over the phone, do that. If it's just a well check, or, I don't really completely understand all the stuff you guys do, but if there's a way to even reduce the amount of in-home visits 25, 30, 40%, that saves lives statistically and mathematically. There's a lot of mathematical models in the beginning, and they basically just showed if we could all just decrease our human contact 50%, we would massively reduce the spread of this disease. And so number one would be using some sort of telehealth or FaceTime or something instead of going there. Number two is if you do go there, wear masks and wear gloves, and wear like a really good mask, like an N95, not just a normal surgical mask. So wear a mask and wear gloves, and bring, like I talk about, you can bring like a little bottle, and I would wash your gloves, like put on gloves, wash the outsides of your gloves before you touch the patient, and then touch the patient when you're done, take off your gloves and throw them away, and do everything you can. Like think of yourself as like you're infected, and how to keep your patient from getting it. Because if they get it, like we said, there's probably a 10% death rate, and that's just not tolerable.
Thanks. A lot of my patients are immunocompromised cancer chemo patients, and that's kind of what I've done. And I've actually put PPE kits in their home, kind of treated them like their own isolation unit. But it's difficult, like you said, when we do have to go in there. So thank you very much for addressing that question.
Thanks, Melinda. And I see Laurel Smith.
Hi, Paul. Great presentation. Thank you very much. And thank you for the human element of that presentation as well. A lot of talk is about asymptomatic. And if someone is asymptomatic, would they even have a fever? So when you're going to a doctor's appointment or something like that, and they're going to check you for a fever first and ask you if you've had any symptoms, if you're asymptomatic, would you even have a fever? No. And could you be spreading the virus when you're not even aware of it?
Yes. yeah. That's the obvious question, and why we all have to be careful. It doesn't mean that screening doesn't work, though, because people who have fevers, they have it, and we know they're spreading. And so let's just say, like New York City, when it got the very, very worst, 20% of people had it. And so the people who had fevers were more likely to be in that 20%, and the 80% weren't spreading it. And so, but there's a lot of people out there that have it for probably 7 days before they get symptoms, and they're spreading it. And that's why, if you were asking me to make all the decisions, I would shut down again. I would shut down the state tomorrow. I would shut down all the churches and the businesses and the bars. And right now, when it's hitting, this is when we have to make action. But in a situation where I don't make all the rules, I just recommend that everyone that will listen to me, if you have the ability to stay at your house and not go out, that's what you should do. If you're in group 1, you should definitely do that, because you just don't know who's spreading it.
Thank you very much.
We'll take 2 more questions, because I know Dr. Lynch has something to get to after this, but Patrick, I saw your hand up.
Yes, good morning, Dr. Lynch. I'm Patrick, and I'm a social worker for Thema Hospice here in Phoenix. Wanted to thank you for your presentation this morning. Everything was so great to listen to. The one area I run into with my families, however, is, as you know from being in New York, and we're seeing it constantly in the news, is families are not allowed to visit their loved ones. What do you tell these families when you see them that, I'm sorry, we can't let you into the house? We're hearing that all the time. But we're also hearing, I want to see my loved ones one last time. They're dying and all this other stuff. What do you recommend to tell those families?
It's a good question. And I'll just say, because I finally opened this chat box and I just see all these comments. I just wanted to thank everyone for all the really kind words, and either privately or publicly. I appreciate you guys. So I actually put my email at the bottom too, because several people asked. I'm just going to tell you guys if you can't see the chat. My email is just my name, which is Lynch, Lynch, MD @gmail.com. And so if you guys have any questions, honestly, if I can help with any of your patients, we love treating the elderly, and I love the work you guys do. So if there's anything I can do to help, please just let me know. To answer your question, you guys have a lot more control in a home setting. I think there's a difference between a hospital where people are dying and there's COVID and we don't want to spread it. And from a public policy perspective, we're making decisions to protect the public. We never want to keep a family member from seeing their loved one, but we also, from a public health perspective, it doesn't make a lot of sense to bring a non-sick person into the hospital, expose them to it, and then take it back in the community, right? So if you're in a situation where there's a loved one in their house, I think they have every right to go see their loved one. And I think what you would want to do is work with them to not get the disease and talk to them about options, and we could spend a lot of, time on that, but there's creative ways to, have the person come outside. Outside is always better than inside. If you went outside and had the loved one sit on their front porch in a chair and you were 6 feet away, that's a pretty low risk interaction. If the person says, no, I really want to hug them, I mean, that's their decision, and help them do that in a safe, way. And so I would just say, from a public health perspective, we need to separate someone who has the disease. But I do think trying to say goodbye one last time is important.
And
Thank you again.
Thanks, Patrick. If we try and sneak in maybe one or two more, if it's okay with Dr.
Okay.
Lynch.
I'm okay.
Okay,
Yeah.
I've got Linda Weitzma.
Hi, doctor. I got on the call a little bit, but my daughter is an ICU nurse at Banner Desert, and I just spoke with her this morning as she got off, and I'd like for you to talk to us about, obviously, and maybe some of the people here know, but there's been a state of emergency within the hospital itself, and there's no beds available. I know Doug Ducey is saying there's 600 beds or whatnot, but there's not enough staff to staff those beds if they're at St. Luke's. So as of this morning, one of my other nurse friends said that they got a call yesterday saying that they needed more nurses, emergency help. These are nurses that are not really nursing anymore. They're just working in another field, but they've kept their nurse's license. And so Flagstaff, Yuma, a couple other places are in desperate need right now. And then my daughter tells me this morning that 50 ICU nurses left Banner in up North Phoenix as of yesterday. So they're bringing 40 traveling nurses into the state. So do you know anything about what the state's doing as far as helping facilitate getting some of these traveling nurses in or doctors to help facilitate some of this?
It's a good question. I would say that I'm not up to speed on exactly what the state's doing. Since I've come back, I was quarantined for a couple of weeks, and then I went back to work, and I've been kind of running my business. I've sent messages to several hospitals just to let them know I'm here if they need me, but they haven't needed me so far. And so I've not really, keep in mind, like, I work in an outpatient clinic all day. So that's just what I've been doing. But I've sent out multiple messages. Hey, if you guys need help, I'm here. It's definitely not what I want to be doing but it's at a certain point, it's going to get completely overwhelmed. And so what I predict is going to happen, if you guys have been following, we're going on about 2 weeks straight of like 1,000 cases a day. And you're going to, now at the 2-week mark, in the next few days, you're going to start to see hospitalizations and death rates really go through the roof. And so I believe our hospital systems will get overwhelmed. I'm praying that there's some miracle, or, maybe the death rate's lower here than it has been. And there's lots of theories and reason to believe maybe it won't be as bad as what we saw in March, but we have to prepare like it will be. That's kind of the key to leadership, is you prepare like it's going to be the worst case scenario. And then when it's not, you go, oh, okay, sorry, we were wrong. So I would say from a preparation perspective, we should be bringing in nurses from all over the country to help. Luckily, we're one of the hardest hit areas right now. And so if every place in the whole country got hit at once, it would be difficult. But right now it looks like Florida, Texas, California, Arizona are kind of getting hit. And so a lot of these nurses that went to New York, I would expect them to be coming here. They're going to need physicians. They're going to need dialysis. They're going to need ventilators. But to answer your question, I don't know all the exact plans that are going on, but I'm going to be available if they need me.
Okay, thank you.
We'll try and sneak in one last one with Nicole, and then we'll move on from there. Nicole?
Yeah, hi. Thank you, Dr. Lynch, for your presentation. It was very heartwarming, and as some people say, it's nice to see the human element brought into it. Definitely need more doctors like you, I say. And so I work in the greater Valley, but our company is based out of the West Valley, and we've seen Surprise do a mask mandate, but we still haven't seen Sun City or Sun City West address the issue. And with my population of membership, as well as our organization's just influence in that area, I was wondering, is this something you're open to kind of taking on the road? Would you be open to speaking to our population about not just your experience, but how important it is to really take it seriously, even though it feels like it's been a long time and we can relax, that it's not actually the case.
Yeah, sir, thank you very much for your nice comments. I feel like as I've gone through all this, I'm not the best anesthesiologist in the world anymore. I'm a pain doc. I'm not like the greatest ICU physician you could ever hope for. But as I think about why, God put me in this position, I think part of it is I can educate and I can teach, and I'm a good communicator, kind of maybe simple, concepts. And so if there's a way for me to get in front of people that might listen to me and change their behavior, and save lives, that makes me very happy. It's something that I'd be happy to do, and it's an easy thing for me to do. So anytime, just let me know.
Wonderful. Thank you so much.
As a compliment to Dr. Lynch, before we send him on his way, he was one of the, I think, the third or fourth signer on the letter to the governor asking for the mask mandate. And he's been doing a lot of radio and a lot of interviews and a lot of stuff trying to educate and show people what's going on with this. So we really, really appreciate you speaking with us, Dr. Lynch, today. And I know everybody appreciated it and got a lot of great information out of it.
Thank you guys for having me. Just let me know if there's anything else I can do. I'm really impressed with this group, Scott. I didn't really know quite what to expect, but a lot of leaders here that have the ability to affect policy change. And so I'm hoping that something I said, made a difference. And if you guys ever need anything from me, I put my email in the chat, and I'm thankful to know all of you guys.
Thanks so much, Dr. Lynch.
God bless you guys.
Take care. And with that, we will turn it over to Steve to see if there's any announcements that the group wants to share. And I know it's tough to follow up that act. But, I told everybody, by the way, a lot of people asked about a recording of this. I'm going to try and get Dustin to edit it down to just Dr. Lynch's talk, and see if we can post that on Senior Healthcare, and possibly share it out via email. Probably be too big a file, but we'll see if we can maybe get it up on the NVCOA website and then on Senior Healthcare Solutions. And with that, I'll turn it over to Steve.
Yeah, Dr. Lynch, thank you so much for the presentation. That was really good information. And I think it's something that here in Arizona, we're going to be needing to refer back to and rely on, especially your 4 points of things that we do. So we see the hospitals getting filled up. I see other updates that they're moving from one hospital to another. I think Mayo's full, and now they're moving them to some other hospitals. So yeah, things are getting ready to get really tight again. So thank you for coming on and kind of letting us know what it's like, to be infected with it and go through that. So how about announcements? Anybody have any announcements of anything they'd like to throw out? Anybody got hands up, Scott? Or
You can unmute yourself if you got an announcement, or raise your hand. Either one will work.
Yeah.
Looks like Nicole had raised her hand.
I think that was from before.
Oh, God.
Yeah.
Well, maybe not then, huh?
Well, if there's no announcements, I guess we will just move on. We hit the 11 o'clock mark. Oh, Nancy, go ahead, Nancy. Oh,
I'm
okay.
just saying hi.
Okay, I thought you were waving your hand like, wait, I had something.
So I think that we're planning on doing an EVCOA Zoom meeting for this next as well. So we'll get those announcements out also.
Yep, we're going to have an EVCOA, we're going to have a WVCOA. All three will be virtual again next month. Nice part is I don't have to tell you to go take your material that you brought with you to the meeting. You can leave it right where it is.
Right, yeah.
I hope you all enjoyed your breakfast, and I hope you all enjoyed Dr. Lynch. I think there's been so much made light of this disease in ways that it should definitely not be made light of. And I think somebody who was on the front lines in New York and got it, I asked him if he would please talk, because that's a hard, to get that perspective from every angle. I thought was really a great way to go. So thanks everybody for coming. Anybody who needs anything, let me know, and we'll try and get that recording posted and see where we can get that up.
Yeah,
Thank
you're
you,
great
Scott.
group.
Thank you,
Stay
Stephen.
strong. Stay
Bless
safe.
you all.
Love
Stay
y'all.
safe. Stay safe.
Take care.
Have a safe 4th of July, everybody.
Oh, forgot about that.
Thanks, everyone. Have a good day.
Thank you.
Thanks, Patrick.
Thank you, Patrick.
Yeah, this standstill universe, when you said 4th of July, I was like, what, July's coming? Yeah. Hard to keep track of time.
It is.
Yeah.
It's even harder for those that are confused.
It's been a definitely compressed timeline.
No kidding. All right, I gotta head out. You guys have a great one. Good to see you.
You, Steve.
Thanks.
See you, buddy.
Thanks for letting me in. Not everybody's so kind, so here we go. Bye.
Thanks, everybody. Take care.